So John will tell us a bit more about shared decision making, and obviously we've heard loads about shared decision making, and many of you are familiar with NICE shared decision document, which is very difficult to read and trying to sort of get points from. Has got very useful tools. We know we need to involve patients, and there is always different ways we should be doing it. And John will hopefully give us some few gems and a few tips from, sorry to say, from consumers' point of view. That's really bad phrase, but that's what really need to know, how patients perceive the shared decision making and how they want to have that done. So over to you, John. Thank you for doing this.
Thank you very much for the opportunity to actually have a part on behalf of CLL support at this really, impressive array of presentations over the next 3 weeks. It is great that you give the patient view the opportunity to air their views, and I hope that I'm able to take the baton and run well with it. So as Renata said, I was diagnosed quite some time ago, actually 1990, when I was aged 32. So quite clearly, I'm the outlier if I refer back to Nick's early first slide. And I have the unenviable statistic of living with CLL longer than I've lived without it. So, and I'm currently on venetoclax, but more of that later. And the positioning of the apostrophe in the title of this talk is critical, as it reflects the collective experience of our members, as well as my own personal viewpoint. I have a fairly low slide count, so let's crack on with it. Now, this particular graphic isn't certainly rocket science, but it says exactly what it shows you there. It identifies the key stakeholders in the process of shared decision making, and the shading is deliberate, as it effectively puts the two teams in play: the doctor, the CNS, the clinical team, and the patient and their partner. Now, there's quite a bit of debate at the moment as to what is the correct term to be used, whether it is a spouse, whether it is a carer, a supporter, a confidant. But for the purposes of this discussion, we're just going to use the word partner. And it's key that all of these people are involved. So we have here the traditional physician, patient viewpoint. Typically, when somebody is ill, they go to their GP and they have a discussion, they outline their symptoms, and the GP makes a decision as to what treatment is appropriate. There is little shared decision-making, really, especially if the situation is an acute one. And typically, the patient will be quite happy with that, especially if they go away with a script and can take some pills, and hopefully their issue is solved. Now, if I had a chronic situation, then there would be more discussion. Or if I had other issues about my health, then surely, yes, there would be more discussion. So having set that scene and understanding that mindset of a typical patient, let's fast forward now to a diagnosis of CLL and shared decision-making. Quite frankly, at that point, it is the last thing that I'd expect as a patient to have to participate in. It's probably as counterintuitive as telling me that I'm going to go on active monitoring. I'm probably ill-prepared to have an opinion on my treatment pathway, and my expectation is that the expert in the room will tell me how, why, and when, and as regards my newly diagnosed condition, which, by the way, comes with the cancer alarm bell, which means that I'm not really going to be hearing an awful lot of what's being said, never mind being asked to have an opinion as to what my new situation is. Now, as Renata said, there is a nice document on shared decision making, but I certainly won't have read it. And if you've read it, well, chapeau to you. It's quite a wordy document. But there is good guidance within it. Now, Apollo 13, it's an interesting situation here. And you might recall it, maybe depending on what vintage you are, from the actual time of the incident, or in the movies or the many documentaries that have followed on from that. But it gave rise to the famous Houston, we've had a problem phase, which I'm reliably informed has been often misquoted. Now, the reason I'm bringing this in here tonight is that I think out with the medical world, the analogy is, or that this situation is a brilliant example of shared decision making. The only fly in the ointment is that it is much more of an analogy, from the analogy is that it's much more of a sort of a peer-to-peer, where clearly from a patient to clinician perspective, it's not a peer-to-peer. But nevertheless, it allows me to walk through the process that developed throughout that very dramatic few days that had the whole world watching. Key to solving this problem was developing trust. Trust in the ground team, trust in the team in space. And yes, they were used to working with each other, but they were millions of miles away, or many thousands of miles away, I should say. And developing trust was clear. The language that was used, the language that we would use between a clinician and a patient, needs to be language that is understandable. I mean, with all the greatest respect, an awful lot of the previous presentation went over my head, and I consider myself to be an informed patient. But nevertheless, if a clinician can articulate the issues at play in an understandable manner, then that means that we have a better chance of being able to participate equitably in shared decision making. If I, as a patient, can communicate my feelings, my concerns, the circumstances that are particular to me in a concise manner, then we're in a good place. Our website has a translate function, by the way. So if English isn't the first language of a patient you're dealing with, you can use that. And we had an example where Sarah, our administrator, was contacted by a CNS last year and said that that particular function made a consultation with a patient who didn't have English as their first language so much more easy because they were able to use it and also translate all of the data on our website. If we can achieve joint ownership of the solution, and it was clear that in the Apollo 13 situation, that's what happened. They had confidence in each other to come up with a viable solution and the ability of the team up in space to be able to execute that solution. We don't have an awful lot, actually, on our own website when I started to prepare this talk on shared decision making. It's something we will change. However, a colleague, a fellow trustee, gave me a site of a document from the Leukemia and the Lymphoma Society of the USA. Inevitably, there is an acronym, PACES, but it actually is quite useful. And in my view, this is a two-way street insofar as the clinician and the patient can use the 5 steps outlined here for their own needs. providing information from a clinician perspective. You provide all the technical medical information, and from a patient perspective, I'll provide my specific circumstances, my concerns, and we can ask each other questions. We can check each other's understanding that what we're trying to get over is being understood. Equally, we can express our concerns. And if what I'm heading towards, or what the physician is heading me towards, isn't quite the way we expected it to be, we can have that open conversation and we can state our preferences. If I hark back to my working days, as part of a management training course, after one lunchtime, in an effort to combat the post-lunchtime slumber, there was an exercise where we were asked to pair up, and we were given a sheet of A3 paper and a Sharpie pen. We were asked to put the paper on the floor and then stand on it and draw the outline of our shoes. And one of us put manager and the other put worker. And a scenario was put in front of us whereby a worker was late coming to work on a regular basis or leaving early, and the manager needed to sort this out. The situation was then flipped, and each of us stepped into the other person's shoes, and the same scenario was played out. And then that was a great example of trying to understand the other person's perspective. And I've remembered it for many years, and it stood me well insofar as there is always another viewpoint that, despite your own viewpoint, you may not understand, and it's only when it's articulated to you that you're in a better place to come to a mutual understanding of the situation. Now, it's also worth saying that there are some people, some patients, who are not at all interested in shared decision-making, preferring the consultant to decide the best course of action, and the patient accepts this. I actually have a friend who's in that camp. They know of my history, my work with CLL support, yet we have never discussed their CLL. And I know from their partner that they just want the consultant to make decisions, and they accept those decisions. And that's okay. So we did a survey last week. We canvassed our members, and we got about 300 responses. Pretty simple graphs here, no great rocket science. So the first question we asked was, have you been involved in shared decision-making? And I think there is a work on here in terms of it's a classic 60-40 split. And we wondered when we saw these results what that actually meant, because the question was so simple. It possibly reflected a number of people who were at such an early stage in their CLL journey that they didn't think that shared decision-making was for them. They weren't as informed, and they were told they were going on active monitoring, and basically that was it. But if it's not that, then it's a work on for both of us. We should emphasize to our members that shared decision-making is an important element, and an element that is appreciated by the clinical team. But the second question was that there was a high answer was that there was a high level of satisfaction to the quality and the experience of people who had participated in shared decision-making. So question 3, was a partner or a friend there to support you? I was a bit surprised by this response. I would have expected there'd be less on the no side, significantly less, in fact. And I think we need to change it. Change this. From my own personal perspective, I greatly valued the opportunity to have my wife with me, and especially on those occasions where critical decisions were going to be made. Throughout my whole treatment profile or CLL story, it was obvious to me when I was coming close to being retreated. And as such, that in itself wasn't a surprise, but the discussion as to what kind of treatment and when, the options that either were or weren't available to me was important. And it was very satisfying and reassuring to be able to have a second pair of ears and an awareness. Now, I'm particularly lucky insofar as my wife is a nurse with experience in oncology, so she can understand more difficult concepts than I could back then. So I do think we need to change that, and there's work to be done by both of us here. So, was a clinical nurse specialist present there or available afterwards to support you? And I have to say, I am very disappointed in this. There's certainly room for improvement, and I think it's wrong that there wasn't. Now, if that's down to resources, then that's hopefully in a paradoxical kind of way the situation. But if it's down to the fact that the clinical nurse specialist wasn't in the room or available afterwards for whatever reasons, then that's poor. In my own personal experience, I had a intervention by a clinical nurse specialist about 10 years ago, which was instrumental in a positive, life-changing experience for me. And as such, I will get on my soapbox and shout out for clinical nurse specialists. I had the opportunity to attend the Scottish Cancer Conference in Edinburgh last November, and I also had the opportunity to ask a question of the Scottish, the Cabinet Secretary for Health and Social Care, to give him his full title, about plans for staffing of CNS posts. And unfortunately, I was fobbed off insofar as the answer was, this is the responsibility of the local health boards. And I know it's challenging. It is really challenging. But we greatly value the input of the CNS. So do you feel that all the options were available and discussed with you? And again, chapeau to the clinical teams, because if you certainly lobbed the green and blue bar together, then that's quite encouraging. The green bar on its own is quite encouraging. Again, disagree. So was around 10%. And there may be a variety of reasons for that. We didn't go into any subsequent questions. And do you feel that you've had enough information to be able to participate in shared decision-making process? And again, that's well done to the clinical team there. And where did you get your information? That's what I'm saying. Well done to the clinical team, because clearly that's valued to be able to get that information. And we also have a part to play. And thankfully, Dr. Google is very low on that scale there. And interestingly, hardly anyone goes to NHS Online. So we asked for a one-word description of people's experience of shared decision-making. I think you can see that it is overwhelmingly positive. And the key word there right in the middle is involved. You see empowering, comforting, and other positive sentiments feature strongly. However, some did find it disappointing or overwhelming. And I think that's a really interesting comment, the fact that some people might find it overwhelming. And that's where maybe because they were weren't as informed or aware of the whole process, or felt burdened by the process. And then we kind of cut a stick to beat ourselves with here, because we asked this question: what is the one thing that would have most improved the experience? It wasn't worth doing a word cloud, because it was a free text response box, and some of the responses were Dear Diary. But the sentiment that came from it was time. And it is time. Time is precious. We know the pressure that you are under, and we can't invent time, but we can use time more effectively. And that's, please, that is not just management speak here. We have ways and means of using the time in clinic that we have sitting opposite you in a consultation. We have the opportunity to use that time as effectively as possible. So if patients and their partners are more informed about CLL, the potential treatment pathways, and have a list of prepared questions to hand when a consultation is taking place, then that precious time slot can be used more effectively. And that's what we try to do in informing our members through our webinars and conferences and the data on our website. And also understanding that the specific circumstances of that patient's situation are different. For instance, a young mum may have different needs and objectives than a retired person with comorbidities. I remember one conference we had down in Cardiff, where we actually had a table of people from our under 60s group. Anecdotally, we call them the youth group within CLL support. But we purposely populated them on the one table, and the discussions they had, and the value of the discussions they had, and the outcome was quite different to the needs and of people who were somewhat older at the other tables. The efficacy of proposed treatments, the progression-free survival data are all important, but they may be outweighed by the side effect burden. And this is what we talked about in the discussion after Nick's presentation just a few minutes ago, when considering their own quality of life. And quality of life is a huge debating point at our roundtable discussions at our conferences. And they're the critical factors for discussion between the clinical team and the patient's team, myself and whatever, confident partner, supporter, carer is with me. And we need adequate time to explore these factors in coming to a decision point. So time is of the essence, and effective use of that time can be enhanced by preparation, especially from a patient's perspective, and we can influence that. So I'm now going to tell you a personal story, which I'm quite happy to share, and it is during the pandemic. The pandemic was a very worrying time for me as a CLL patient. I was shielding like many, many others. I felt personally very vulnerable in uncertain times, and vaccines were the thing of dreams at the early stage. Now, at that stage, I had been on ibrutinib for about 6 years and was keeping well. But, and as Renata mentioned, I was regularly cycling long distance and tackling some tough climbs. But late in 2019, my blood counts started to go the wrong way. And over time, the trend was quite clear. And in the April of 2020, it became clear that something wasn't quite right. Consultant in a telephone call, because we weren't going into the hospital. And I had a great relationship with my consultant. I actually hate using the word my consultant. He's not my personal consultant, but we had been together since 1996. So we knew each other well, we had a good understanding, and his advice at the time was that there was no rush to action. However, and venetoclax was a viable option. My view, however, was somewhat different. I was in good shape. I was in the best place, I reckoned, to make a transition from ibrutinib to venetoclax. Who knows how I might handle it later on when maybe my general health deteriorated, and who knows at that stage what was going to happen in the pandemic. So despite having a worry about going to a hospital, even as an outpatient, and the fact that we had a great discussion on the pros and cons, and the fact that there were some unknowns, we decided together that we would actually start preparations and transition to venetoclax. I, from my perspective, effectively completed a balanced scorecard to help me shape my thinking. My wife was listening onto the conversations, but there wasn't any CNS involved. But that was down to resources at the time. I think they were reallocated elsewhere. In the end, the risk of tumor lysis syndrome proved to be too great, and I was admitted as an inpatient. But I kind of expected that that might be a possibility. And at that stage, having had a couple of visits as an outpatient to the hospital and seeing the situation on the ground rather than the media hype that we were exposed to continuously on the TV, I was comfortable with that at that stage. But from my own perspective, that was a really good experience in terms of shared decision making. And I hope you can understand why I'm an advocate of shared decision making. So my last slide is another sort of film related aspect insofar as it's a little bit back to the future. As you can see, I'm using the same graphic I used at the start. However, deliberately so, I'm using the same graphic. There are 4 stakeholders shown here, but in reality, the 2 key players are the doctor, general doctor, consultant, registrar, junior doctor, whatever, and the patient. And those 2 are really have their own agendas to a certain extent, their own concerns, their own worries, their own pressures. And certainly from a patient perspective, the diagnosis of CLL can be a very isolating experience. It can be a challenge for a doctor to engage with an upset or defensive patient, just as easily as a patient might find a doctor to be rushed, not interested in their situation, their side effects, or dismissive of their concerns. So we can get into a me mindset. And my use of text color here is actually quite deliberate because it can indicate a potential conflict. So what do we do as patients? What do we want from shared decision making? We want a seat at the table where our viewpoint and our particular circumstances are valued and taken into account. And if our issues can't be accommodated, then a rational and reasoned explanation is tabled by the clinician in an understandable manner so as we can accept that logic. Like I've used the example of in your shoes that I mentioned earlier, when we try and understand each other's viewpoint, then we get to a better place. So looking at the 2 letters in me, if we use our mind's eye to just flip over the M, this is what we get. And all of a sudden, the situation of potential conflict or disagreement or lack of trust or not having the ability to own a solution has been transformed by virtue of the fact that we are in a situation where we can accept and reach a positive and rewarding conclusion to our shared decision experience. Thank you for your time.
Thank you, John. That was really insightful and very interesting, very good, interesting story. And thank you for sharing your experience from pandemic. That must have been really, really scary, especially sort of making decisions on the phone. That's something which hopefully we won't have to do it again. With the survey you've done with the members, to see that 40, as you said, 40%, maybe that those 40% who did not felt, because indeed, it's quite an interesting sort of philosophically. You give people diagnosis of CLL. Well, there is no shared decision making in that, isn't it? This is it. And in a way, there is no shared decision in the decision on treatment, because you land this C word into the court and then say, I see in 6 months' time, or you don't need to worry, you need blood tests. So this is non-shared decision making of active monitoring. And I really liked when George, I think during one of those sessions we're doing here, you told us about the way you do it. So when we actually tell the patients they've got the C word, the CLL word, and then we won't do anything, don't worry. But I think the way to do it is the way you doing it. So I remember you said that you don't sort of invite patients for full 40 minutes or 30 minutes consultation. You spread it into short bits. Could you tell us how do you do it, or maybe even in ideal world, how would you like to do it to tell patient, yeah, it's CLL. You've got no choice in that. And yeah, it's going to be watch and wait. And you've got no choice in that either.
Oh, Renata, there's so much in communication skills. So this afternoon, I had a distraught second opinion came in from somewhere else because he, age 72, bright guy, had been told the words were an incurable cancer that will gradually get worse and then we'll have to start to treat you. Now, this guy has a stable lymphocyte count of 10, mutated IGHV, 13q deleted, 72, completely fit, no medication. And it's within seconds, it's obvious to anyone who's actually up to speed in the CLL world that this chap's probably never in his natural lifespan going to have problems from his CLL. And even we had 3 years of data with a stable lymphocyte count of 10. So communication is everything. And it takes just 15 minutes having a conversation of thinking, well, look, sometimes you think about the aging of the immune system, and CLL is a bit of a different form of wrinkles that you get in the skin. And of course, that's simplifying things too much. But CLL, for quite a lot of our patients, can arise as part of the natural aging process. And thankfully, for a good chunk of patients, when you're talking about early stage, et cetera, who are diagnosed in their 70s, can have a good quality of normal life, and how you conceptually think about it. I'm only coming in with that point because hearing John's story and making us realize, particularly, I hadn't realized, John, your journey was so long. That, I think, might be the longest I'm aware of in the UK. That is amazing. But it reminds you how many times that over all these years you will have these critical junctures. And I think the bit that Renata's mentioning there about my previous comments, that we all know, particularly when you're new to this diagnosis, that information overwhelms really quickly. And you've got this dichotomy, you've got this desire to know everything, and yet this simple fear of knowing everything. And we all know that if you think of any aspect of your life which causes you stress, whether it's tax return, mother-in-law, seeing the vicar when you haven't been to church, all these things, we all know that stressful things, that they set your brain going and you go, oh, tax return, oh, I'll get it. And think of that when we're clinicians, because we haven't experienced this, sitting there, or most of us haven't experienced, and being suddenly faced with these words when prior to that first meeting, you were a fit, recently retired person who had just been, et cetera. And so the strategy that we've evolved in our clinic is the discussion with me to try and put a broad thing on it, a broad picture, discussion with specialist nurses. John, I hear those points. Our nurses are so invaluable. It's amazing. Another patient today I noticed was talking to me, actually was talking to the nurse all the time, would occasionally look to me, and I was trying to work out, is this patient frightened of me? I was sort of looking around the corner saying, I can have eye contact too. It makes you realise some patients actually naturally they form that bond. It's amazing. All human beings are different, and we've got to work with that. But I do believe in these short meetings where possible, return to themes. So we've talked about, A, B, C, and we'll go further with that. And my last point, I do really believe at the heart of CLL is with the shared decision making, is this negotiated decision making. I always say that with my patients. If we think about our practices, all three of us clinicians are on this panel now. We're all very busy. How many times in the last 12 months did you have a CLL emergency? I suppose you've got hemolysis. You get the odd Richters, but most CLL treatment decisions, they're negotiated start points. The patient's kind of a bit more tired, a bit more anemic, and you'll say, we've got your molecular profiling back, and I guess we are going to think about, 2025 might be the treatment time. You know what it's like. And so I think it's that constant helping with that shared decision making. You are involved, the patient is involved. Of course, John did point out that key thing that I don't know what the figure is, a quarter or a third of patients, they won't be the ones signed up to CLLSA because they just turn up and say, Doc, whatever you say. And, you're trying to drag out some shared decision making and they just don't want to do it. But many patients do appreciate it, even if you've decided this patient's going to get venetoclax obinutuzumab, I want it. But you, of course, never get to that point using that strategy because you go, there's A versus B, and we can think about the advantages and disadvantages and then have a chat with Gwyn, and then we'll meet again. Come back in a week's time, 2 weeks' time, and perhaps come back in with your partner. John, I love that point. It's very difficult, isn't it, when you're only speaking to one person, that they can have continued discussion about the points you raise if there are two of them there afterwards when they go on home. So very long answer, Renata. You should have dragged me in. I talk forever. So I will stop.
It's very, very useful. I think the other important thing, which I'd love to, John, for next session, just maybe check that, it's actually a letter. And I think it's really important to obviously have those meetings, have those discussions, but the letter we send to the patient, free of jargons, laying out, as you said, George, option A, option B, maybe it might be option C. So the patient, I had one situation where I thought I was as clear as I could be, and then I lay down in my letter, and then patient comes back to me with that letter. Well, your letter doesn't say anything where you actually said it to me. So it's just kind of going back. Well, I would disagree, but obviously, patient is always right. Let's go back to the drawing board.
Possibly.
And let's discuss again. But I think, for me, that was a big lesson, that whatever I say, I try to reflect closely in the letter. So that letter is for them a notes to kind of think again, because like John was saying, it's important to have a next pair of ears when you go for consultation. Letter is kind of another next pair of ears, except obviously it's right. I would be interesting what you think about the letter and how we should do letter, and obviously avoiding the jargon.
To have the information given to you in a manner in which it is understandable from a non-medical person is key. But I will possibly surprise you here in saying that not all CLL patients get a copy of the letter that goes to the GP. So that is not right across the board. And I think it's possibly also down to the CLL patient asking for a copy of that letter. But not all patients get it. It is physician to physician.
I think I would plead to all attendees, if you are healthcare professionals, please. I know it's I've got to say, when I made that leap to say all my patients will get my letter, the way I typed that letter completely changed.
But Renata, can I just clarify? So we have a hospital policy. Every patient gets a copy of every correspondence, and we made that change a decade ago. But there's still merit in defending the clinician-to-clinician letter. And I think we have this debate a lot in our department, and it's a 50-50 split. So some have taken the Royal College of Physicians guidance and do a, dear John, thank you for going back to clinic today. We're going to treat you with tablets that are called sacked, and then go through that sort of descriptive thing. And other clinicians take the more medical legal perspective that actually a letter is documenting a decision-making process that has to have technical words in. And the challenge, of course, is if you're, say, the interim PET scan was a Deauville 4, if you're going to start explaining that in every letter to your patients, you create a lot of extra admin time. And it might be that in your clinical practice, that's deliverable. But I think because the letter serves as a medical legal reference point as to where you are in case management, there are these arguments. And strangely enough, in my practice, I've now evolved Crux decision points. I have my standard GP letter. We talked about the fixed duration, we're opting between as medical expenses. But if you feel that patient needs one, dear Mr. Jones, we talked about following this German trial thing, and this is what we're going to do. We're going to bring you up on Thursday. And so writing 2 letters about the same event, that sounds a bit strange. I don't think other people do that. But for me,
do you do that within one letter? Or do you
no,
do
then we'll
separate
do
letters?
a separate letter. But the patient will get copied on the clinician-to-clinician letter.
Okay.
Just for me, they're different documents. And actually, most of your routine stuff, Mrs. Jones attended, she's been on ecalibrating for 8 months, she has minor loose stool, grade 1, that doesn't actually need to be a, dear Mrs. Jones, thank you for coming up, I note you still have minor. If you see, that's my mindset. But within our department, I fully admit there are different viewpoints on that. And, there are 60 attendees today, half of them will have one view on that and the other half will think the other. So.
Yeah. Lilia, if I could bring you in, do you have any sort of comments of what we just discussed about maybe letters? I remember you said once that obviously with diagnosis, it was two weeks you had to take first ever off time of sick to cope. Yeah. Any comments you would like to?
I mean, that's a different issue to the letter. I mean, just the last comment on the letters is actually that often the NHS vagaries are you get them weeks later. So they're actually not hugely helpful if you don't get them for like 4 or 5 weeks. Often, I mean, I hear stories of people where they've actually had their next clinic appointment and then they get the letter from the previous one, which can be more confusing. But I think that's not a clinical issue. That's an NHS admin issue. But I was reflecting when John was talking, actually, that I think you touched on something that I think is quite important, John, which, as George says, you've got a long history. And you made a point of saying that the hematologist that has worked with you for a long time, almost since the beginning. And I think it's really, I agree completely, it's all about communication. And I think that's actually much more difficult when people are seeing different clinicians every time, which does happen quite a lot when you listen to folk in the CLL community. And it's particularly so when it's largely telephone consultations. And some units are still, as far as I can make out, largely doing. I have, just to use an anecdote, I talk regularly to someone in her 80s with CLL. She's had a change of consultants and she's never met that person because she's just told no whenever she asks for a face-to-face appointment. I keep telling her, just keep pushing. But it's just, if we, and the issues of CNSs, I don't think every hospital has them. So I think her hospital doesn't. She goes to the local district general. But I think that continuity of care and taking time, it's a bit like any relationship. It works better when sometimes you do click instantly, but it works better when you've got time to get to know somebody. And I think one of the things, maybe again, to add to the discussion is that you in the hematology community are seeing patients with CLL, people with CLL, for those of us with CLL, it's just one aspect of our lives, which John brings out very clearly. And I think that's another element to just take account of. And it means it's different language, works for different people. And it's also part of that getting to know people. So I think that's not, those are just comments, really, reflections back when I was listening to John talking.
You're right. If I've got a good relation with a patient, I've discussed the topic quite a few times. If there is a problem, I can just pick up a phone and just have a quick chat, just kind of straighten certain things out if something is not going quite right. And I think, this can, there are those really, sometimes, because obviously we've got pressure of time, sometimes those quick communications, and then just say, well, let's chat a bit more in depth about this in our next appointment. Yes, and actually meeting people, because obviously of post-pandemic, there's loads of people still being seen on the telephone. You lose so much in a telephone consultation, and I think once in a blue moon, it's good to actually bring those people back and have a normal face-to-face conversation.
And some folk find that any telephone conversation is difficult. Everybody's different, and again, I think that's part of the getting to know each other as a person with CLL and a clinician working with them.
Thank you very much, all. And hopefully I'll see you all, and bring your colleagues all over next Monday.
Thank you very much, Renata, John, Lelia, and Nick. Thank you.